One of the most common issues I deal with in my practice regarding men's sexual health is premature ejaculation. But do all men who come in with this complaint actually suffer from premature ejaculation? Is their self-diagnosis correct? In this video, I'll cover everything you need to know about this condition. Today, we're going to discuss all the essential information about premature ejaculation. Before we get into the definition, let's start with a quick overview to set the stage. Sexual intercourse is typically divided into 3 stages. The first stage is related to libido. The second involves arousal and erection in men. The third stage is orgasm, which usually coincides with ejaculation. Ejaculation can occur too early, disrupting the patient's sexual quality of life. This is a very common and frequently discussed issue. Before we discuss the definition, what's considered a normal ejaculation time? There's no clear consensus on this. It's a limit that varies by country, region, and study. Generally, the average is 5 to 15 minutes. That's the typical time from penetration to ejaculation. This is considered the normal ejaculation time frame. Defining premature ejaculation is also subjective. Why? It's directly tied to the couple's satisfaction. This varies greatly between individuals. To help, the ISSM defined 3 diagnostic criteria. First, ejaculation time around 1 minute. Second, the man has no control over ejaculating. Number 3, when the couple's sex life quality is significantly affected by the 2 factors I just mentioned. The diagnosis of premature ejaculation is primarily clinical. You'll talk to the patient, he'll describe his symptoms, and you'll make the diagnosis. There's no specific test we can use to measure or grade the level of rapid ejaculation. Premature ejaculation can be divided into 4 types, with the first 2 being most common. Primary premature ejaculation is typically seen in patients who've always lacked ejaculatory control throughout their sex life. These patients often have issues with their neurotransmitter receptors. Number 2 is secondary premature ejaculation. This secondary form is typically linked to other issues like hormonal changes, erectile dysfunction, or psychological factors, which we need to address together for improvement. The third type is natural premature ejaculation. This type usually improves on its own over time. The patient suddenly develops this issue, often tied to a new phase in life, but it generally improves naturally without intervention. The fourth type doesn't fit into any of the other 3 categories. It's when a patient is unhappy with their ejaculation time, even though it doesn't medically qualify as premature ejaculation. So technically this patient isn't ill, but they're dissatisfied with their situation. When treating premature ejaculation, it's crucial to tell the patient that there's no miracle cure. There's a well-established treatment that, when followed seriously, has a substantial success rate. Then we can explore our options. First, treatment with psychotherapy. These conditions are often linked to anxiety and sometimes depression. So sex therapy plays a crucial role alongside clinical treatment. Clinical treatment can involve oral or topical medication. Among oral drugs, we have duloxetine, which is the only drug authorized and approved by the FDA. The FDA is the American equivalent of Anvisa. It's a medication used as needed. It's a serotonin reuptake inhibitor that works to prolong ejaculation time. It should be taken 1 to 3 hours before sex and only when the patient plans to have intercourse. Other commonly used drugs, which are actually the ones we use most often in our practice, are medications that are in fact antidepressants such as nortriptyline, fluoxetine, and clomipramine, and we utilize their side effects to treat premature ejaculation, which has shown good results. It's quite effective. Often these cases of rapid ejaculation are associated with erectile dysfunction. So it's important to combine a PDE5 inhibitor like tadalafil or sildenafil, as patients who can better control their erection will consequently have better control over ejaculation. So, when we diagnose a patient with this secondary condition, erectile dysfunction with ejaculation issues, we use a combined approach. What can we use for topical treatment? Sprays and gels. It's typically a mix of anesthetics like lidocaine and prilocaine. This anesthetic is applied to the penis before sex to reduce sensitivity. There are pros and cons. It can cause discomfort, potentially leading to loss of erection or sensation. Being a topical anesthetic, it might transfer to the partner, numbing her as well. This can create an awkward situation. It's not commonly used. Remember, all treatments should be prescribed and monitored by a doctor. All medications for rapid ejaculation treatment are controlled substances requiring a prescription. Doctors must monitor patients, assess comorbidities, and treat other sexual dysfunctions for comprehensive care. A quick note about surgical treatment. There's no proven surgical treatment for rapid ejaculation. Various attempts exist, but none, including circumcision or phalloplasty, are proven effective for premature ejaculation. If you enjoyed this video, if you found the topic interesting, if it was helpful to you or might help someone else, please share it, like, subscribe to the channel, and turn on notifications for future content. See you next time.